So, thank you very much for the invitation first, Professor Yankov, dear audience, dear colleagues. Today I am going to present you recent developments and new approaches in corneal crosslinking. First I start with the facts. They are more or less already mentioned by Professor Yankov. Then we go on to the current state of clinical crosslinking. Afterwards I'm going to tell you about approaches to decrease the irradiation time. As we heard that 30 minutes of irradiation is quite a long time. We go on to the ways of increasing the efficiency of crosslinking. And the last topic is new investigative techniques of crosslinking. So, facts. First, what do we know about crosslinking? During crosslinking, oxygen radicals are produced, and they produce new chemical bonds between neighboring molecules. This was first shown in 2003 and reproduced in 2013. Here we have an untreated collagen fibril, and here we have a UVA riboflavin-treated collagen fibril. We can see that we do have intra as well as intermolecular new bondings in the collagen fibril, as well as we do have new bondings or new bonds between the proteoglycans. Here, intra as well as interproteoglycan bindings. So, how can we measure the stiffening effect of the cornea? Therefore, we do stress-strain measurements, and in humans, these stress-strain measurements showed us that the cornea becomes a factor of 4 stiffer. This was first proven by Professor Spörl in 1997 in Dresden, and let me show how he did this. This is a typical stress-strain aperture. We can see the cornea strip that was excised from the cornea with a width of 5 millimeters. This is then climbed between 2 jaws and stressed until a strain until 12% of its original length. The stress is continuously measured of the cornea strip, which leads us then to such a relation, a stress-strain relation. We can see that without the crosslinking, we do have lower stress values as with crosslinking. So this was made in portion corneas, where we just do receive a factor of 2 for stiffening. But you can also see this from the eye, as we have seen at the presentation of Professor Yankov. Here you can see a non-crosslinked strip, and on the upper part you can see a crosslinked strip. So you even can see the fact of crosslinking by eye. So the next thing, how we can measure crosslinking, or how we can see that crosslinking took place, is the biomechanical action. Because if we lay down a cornea that was crosslinked and compare this to a cornea that is not crosslinked, if we put this in a solution with collagenases that digest the cornea, we can see such a graph. Here we do have 4 groups. The first group is untreated corneas, then corneas that are just exposed to riboflavin, corneas that are just exposed to UVA, and corneas where we've done the crosslinking. Here we can see that the first 3 groups, the cornea is digested within more or less 6 to 7 days. The same cornea, but with the crosslinking, or corneas with crosslinking, are much more resistant to collagenases, which you can see that we do have an increase of resistance to collagenases that is at least twice the amount. So, current state of clinical crosslinking. This is the so-called Dresden protocol. As the first crosslinking procedure was developed in Dresden, we do the epithelial removal with a diameter of 9 millimeters. This is because here you can see the molecule of riboflavin monophosphate. This is the riboflavin molecule. Here we can see the phosphate so that we can dissolve higher quantities of riboflavin in water. As this is a very large and big molecule with a molecular size of more than 300 Daltons, we need to remove the epithelium, because otherwise it could not get into the cornea, because the epithelium, the riboflavin can't penetrate through the epithelium. I will tell you later on this topic. So we use 0.1% riboflavin in a 20% dextrane solution to keep the hydration of the cornea constant, followed by UVA irradiation of a wavelength of 365 nanometers at the energy density of 3 milliwatts per square centimeters for 30 minutes. The total energy that is applied to the cornea is 5.4 joule per square centimeter. With that Dresden protocol, we do get an average cross-linking depth of the cornea of about 300 micrometers, and therefore we need a minimal thickness of 400 micrometers to protect the endothelium. So, safety. The Food and Drug Administration in the United States define a complication if we do have a loss of more than 2 Snellen lines after an ophthalmologic procedure. We do have a complication rate in cross-linking that is less than 1% after 1 year of the postoperative control. We could identify, in our group in Zurich, we could identify 2 risk factors. The first risk factor is the age, if we do have a patient that is older than 35 years. And the second risk factor if the best spectacle corrected visual acuity is more than 20/25. Failure. We have defined the failure of the procedure if the Kmax readings increased of more than 1 diopter 1 year after the treatment. We do have this failure rate in about 3% of the patients treated. There we could identify one risk factor if the keratoconus was already quite progredient, and we do have a Kmax reading of more than 58 diopters. So this is a bad prediction factor. So the stability, we've seen this picture just 5 minutes ago from Professor Yankov. This is the Kmax readings before cross-linking, and we can see that after cross-linking there is a flattening rate of the cornea. We don't know when it stops, but this is a 4-year control, and we can see that it continues to 4 years, at least 4 years. We've also seen this picture before. It's just preoperative. We can see a Kmax reading of about 47.5 diopters. After the treatment, it went down to 46, 45.5 diopter. After 4 years of the treatment, we went down to 45. And 8 years afterwards, we are down at 44, 44.5. So we can see that we do have an increase till 8 years. And this may continue for another 2 or 3, or I don't know how long. We don't have those post-operative controls yet, but we will see in the future. So there the visual acuity. After cross-linking, we can see that in the beginning the visual acuity decreases. After cross-linking, it increases of about 1 Snellen line, and at the end, after 4 years, what we do have right now, we do have an increase of about 3 Snellen lines, which is significant. So we already heard about the problem of very thin corneas. What can we do here? Before the cross-linking treatment, this patient had a corneal pachymetry of 370 micrometers. So what can we do? Does anyone have an idea? Okay, I'm going to help you. We just use hyperosmolar riboflavin. There we use the fact that if the epithelium is removed and we apply hyperosmolar riboflavin, the cornea swallows. We do receive a thickness of more than 400 micrometers, so we can perform the cross-linking that is safe for the endothelium, and we don't hurt the endothelium or damage the endothelium. So the clinical results, cross-linking appears to be safe and effective. The regression is not predictable, or not yet predictable. Maybe in the next years we know if it stops, when it stops. As we've heard from Professor Yankov, the collagen are reproduced every 3 to 10 years, so maybe we know in 2 or 3 years we know more, and the regression may continue for years. So approaches to decrease the irradiation times. As we've heard, this is we do have the abrasion or the epithelial removal. Afterwards we do apply riboflavin for 30 minutes, and then we irradiate another 30 minutes, so the patient is for at least 1 hour in your operation room, and this is very uncomfortable for the patient, and for you as a doctor that's also a problem. So we thought of how to decrease the irradiation times. Here I would like to show you the results from the Zurich group and the Geneva group. The green ones are from the Zurich group, and the yellow Balkans are from the Geneva group. We can define that at 3 milliwatts per square centimeter, with a time that we irradiate of 30 minutes, we make here the baseline for 100% of the biomechanical effect. The next graph that next Balkan I want to show you is if we increase the energy fluence by a factor of 3, we can decrease the time by a factor of 3. This gives us a more or less same effect of corneal stiffening. And the energy dose is always the same, because 1 per second, so if we decrease the time and we higher the energy density, so we do have the same energy applied on the cornea. This slightly changes after when we apply 30 milliwatts per square centimeter to the cornea. And there we have converse data, because the Geneva group just found out that the corneal stiffening effect is just half of the rate as we do have when we irradiate with 3 milliwatts per square centimeter. And at 50 milliwatts, the effect, both found out that the effect is much weaker. So this is from the Zurich data, and this is from the Geneva data. So we can say that we can go down with the time, or we can raise the energy up to maybe 12 or 50 milliwatts. That's a safe procedure, as well as it is a very effective procedure by terms of biomechanical stiffening. Can we shorten irradiation by higher power? The answer is yes, we can shorten irradiation time, but however we need to have prospective studies. What we found out, that we do have a stronger inflammatory reaction on the eye, such as we do receive more haze, and for the patient it's more uncomfortable. And what you always have to keep in mind, that too high energy doses may harm or may damage the endothelium. The next thing, can we shorten inhibition time? Professor Yankov already showed this. Just want to run through this. We have the riboflavin concentration and the time, and in which depth we do have enough riboflavin to produce cross-linked collagen fibers. Here we do have it after 5 minutes. We can see that we just have a high enough concentration to perform cross-linking in the first or in the anterior 100 micrometers depth. After 50 minutes we are somewhere between 200 and 300 micrometers, and after 30 minutes we do have more than 300 micrometer steps, which is enough to halt the regression of keratoconus, the progression of keratoconus. Can we shorten inhibition time? Yes, we can shorten it, but this gives us a shallower effect of cross-linking, and so we do have we do have not the same effect to halt the keratoconus or to stop the keratoconus or the progression of the keratoconus. So the next thing I want to show you is the ways of increasing the efficiency of cross-linking. So what do we have here? Someone want to tell me what we have here? Or what you can see in this picture? Yes? Yes, we can see the very good. We can see the demarcation line. This is an anterior OCT of the cornea. We can see the demarcation line here. You can see it here. The next picture. We can see the part that is anterior to the demarcation line. That gives us the part of the cornea that is cross-linked, and the part behind the demarcation line or posterior to the demarcation line. This is the non-cross-linked cornea. Now, as we can see in this picture, that in the center of the cornea we do have a thickness of about 300 micrometers, but in the periphery of the cornea we do have a less effect or a less deep effect of cross-linking. This has to do with the first UVA devices that are irradiating. Therefore, we had a homogeneous beam profile where we did have everywhere the same amount of energy that was applied to the cornea. As we now see that there's a difference in the angle how the UVA is applied to the cornea, we do have a less intense effect of cross-linking, because here we are perpendicular to the cornea, and here we aren't perpendicular to the cornea and the periphery, and that's the reason why we do cross-link a lower volume of the cornea. So here we can see the old beam profile with the intensity, with the total energy absorbed in the cornea. We can see that in the center of the cornea. We can see in the center of the cornea, we can see a high energy that is absorbed. So there we have the whole 300 micrometers, and in the periphery of the cornea, we do have less. That was the reason why we thought, how can we improve this? So we just changed the beam profile. We changed it to the so-called donut profile, where we just use higher intensities of UVA light in the periphery, so that we receive the same effect in the periphery for corneal cross-linking. And this is the Avedro lamp from the United States, which is in between. So now we have another OCT, an anterior OCT of the cornea with a new lamp, with a beam-optimized lamp. We can see that in the center we do get about the 300 micrometers of depth that is cross-linked of the cornea, and at the periphery we do get the same. This is also very important because most of the keratoconus aren't in the central cornea, but they are in the periphery of the cornea. So we definitely can increase the efficiency of corneal cross-linking due to changes in the beam profile of the UVA light. There I want to show you the 12-month follow-up of the patients. We do get a flattening rate of 1 diopter with in 95% of the patients with the new profile, with the donut profile that I showed you right now, and with the old profile where everything is homogeneous, we just get 37% of flattening rate of more than 1 diopter within 1 year. With the flattening rate of 2 diopters, we do have this in more than 65% of the patients, whereas we just received 13% flattening rate of more than 2 diopters with the homogeneous beam profile. The complications are similar to the old lamp, but as we also applied in the new lamp the higher energy, the 10 milliwatts per square centimeter, with a short irradiation time, we do get a general stronger inflammatory reaction, as I told you before. So let's go on to the new investigative techniques. First of all, why do we want to keep the epithelium? This has to do with the complication rate. First, we do get sterile infiltrates in about 8% of the cases when we perform cross-linking. You can easily see this here in the periphery. They are always in the periphery, and they are easy to treat with topical steroids. The next thing that we receive in about 3% are stromal scars, where you can see here. But indeed, this is not a complication, or not a complication as you think, because there is an advantage of stromal scars. Here you have the keratoconus before the cross-linking treatment, and here after the cross-linking treatment. And due to the CAR, there's a much more effect of flattening in the cornea. And if we have a look at the follow-up of this patient after, this was 3 months, 6 months, and 9 months, we can see that the scar disappears and the flattening gets a little bit, the steepening of the cornea gets a little bit higher, and so we almost receive almost normal cornea in the topography of this patient. The last thing that we may have delayed epithelial healings in about 2% of the cases. This we can see here. Normally the epithelium heals in about 3.5 days in the average after cross-linking. This patient had a delayed epithelial healing at day 6 or 7, and 2 days after the epithelium was closed, we just saw this fungal infiltrate, which was, by the way, also treated by corneal cross-linking, which another doctor is afterwards presenting. So can we avoid the epithelial removement? The first approach was from the Italian group, where they used Tris and Editar in addition to the riboflavin and the dextrane to lose the tight junction of the epithelium, so that the riboflavin can pass through or transepithelia into the stroma. The earlier props proved the clinically effect and the halt in the regression of keratoconus, and histological studies showed minimal side effects, but there has not been any basic research on this topic. So there were no experiment on portion corneas or on rabbits. They just went directly into a clinic. So Professor Spörl from Dresden, he thought, let's do the experimental data there to see if this really works or not. So here he also compared the biomechanical effect of the control group of untreated portion corneas and of corneas treated after the Dresden protocol. And then if we see with the Ricolin TE what the Italian group says that would be the future of crosslinking, we can see that there is an effect of crosslinking, but the effect is much more lower than the effect that we do receive with the epithelial removal. So this has again to do with the riboflavin concentration in the stroma. We can see that at the epi-off method, after 30 minutes, we do have enough riboflavin in the anterior 330 micrometers to perform crosslinking. With the epi-on method, with the Ricolin that was suggested from the Italian group, we just have a high enough concentration of riboflavin in the first anterior 100 micrometer of the cornea, which is definitely not enough to halt the progression of the keratoconus. And then in August 2013, they produced a paper and published the paper in the Journal of Cataract and Refractive Surgery, where you can see that preoperative you have a Kmax reading of 48. Then the 1 month, 3 months, 6 months postoperative controls, they were just normal as they told us, so progression was halted. But then if we go on to 12 months, 18 and 2 years, we can see that the progression of the keratoconus still continues. We don't have a halt in the keratoconus, and the keratoconus is not healed. And then they told us they had a recrosslinking rate with the epithelial removal method of more than 50%. So this method, you can just don't remember this method, this is just useless. So, as I told you, we just have a very shallow crosslinking in the first anterior 100 micrometers. The demarcation line just shows this, that there are just the anterior 100 micrometers are crosslinked, and there's no long-term flattening of the cornea and no halt in progression of keratoconus. Then the next approach for transepithelial crosslinking, this is what we are investigating in Zurich, is to apply the riboflavin into the stroma with a channel system that we create with a UV femtosecond laser that you can see here in a depth of 300 micrometers depth. We just did the investigation 3 months ago, and we just have done this on portion corneas, so there was no application yet in human studies or human corneas. Afterwards, we do the injection of 0.5% riboflavin, so we do have a higher injection of riboflavin in the cornea. You can see that the channel system is normally flooded with riboflavin. Afterwards, we wait for 30 minutes so that the riboflavin can diffuse in the cornea. So we also do have high enough riboflavin concentration in the stroma to receive the crosslinking. Then, as a lot of people ask us, hey, you cut, or you already cut a cornea that is very weak. How much do you cut, and are you sure that there is no more weakening due to the channel system? So we calculated it, how much we do separate, or how much we do dissect of the cornea, and we just dissect less than 9% of the cornea with this femtosecond created channel systems. Then we compared 4 groups. So this was just presented 1 week ago at the Crosslinking Congress in Dublin. We compared 4 groups: 9 untreated portion corneas, 9 portion corneas treated with the Dresden protocol, 9 portion corneas treated with the intrastromal channels, but instead of using riboflavin, we just injected BSS, so the salt solution, and UVA radiation of 4.5 joule per square centimeter. And the last interesting group, we did this on 9 portion corneas with intrastromal channels, and an injection of 0.5% riboflavin. Waited for 30 minutes to let the riboflavin diffuse, and afterwards we had the UVA radiation of again 5.4 joule per square centimeter. Then we performed stress strain measurements. We excised the 5 millimeter wide strip vertical in the cornea. We performed stress strain measurements between 0 and 12% strain. This is our stress strain machine with which we perform the measurements. Here you can see the two jaws. In between the two jaws there is the corneal strip clamp. Then the left jaw is connected to the motor. The right jaw is connected to the load cell where we measure the stress. And all the measurements, because such a measurement takes about 5 minutes, we do this in a bath of 20% dextrane to keep the hydration of the cornea constantly, so that we don't get any artificial values or any artifacts. So as a result, we just get such a stress granulation as I already showed before. And furthermore, we investigated the UVA transmission to prove the safety of this treatment. We compared 5 untreated corneas, 5 corneas treated after the Dresden protocol, which we know is safe, and we also compared our group with the 5 corneas with the intrastromal channels and the injection and the diffusion time. So if we now compare the UVA absorption of this intrastromal approach, this gives us an absorption rate of the UVA of about 42% in untreated corneas. The Dresden protocol has an absorption of about 91% of the UVA irradiation that is exposed to the cornea. And with the intrastromal application, we do have about 98% of absorption of the UVA radiation. Then the interesting thing is the stress strain measurements. We can see here the group of the untreated corneas as well as the group treated after the Dresden protocol. You can already see that this is almost a stiffening factor of 2, which was proved by Professor Spörl in 1997 in the first paper, so this is nothing new. Then we just compared the group number 3, the intrastromal channels without cross-linking. There we can see that there is no significant change in corneal biomechanics due to the channel system that was created. We even get a little bit stiffer cornea, but this is just a not significant change in the stiffness. Then the interesting group, you can see it's quite close. The interesting group with the intrastromal channel system with the riboflavin and the cross-linking. We can see that this is quite close to the Dresden protocol. And now if we compare the stress values at a strain of 10%, we do receive an increase of corneal stiffness of about 81% with the Dresden protocol. With the Dresden protocol is a protocol that is right now used in human eyes. Intrastromal application gives us an increase of 64% of corneal stiffening. So we can say that the increase of stiffness after intrastromal application of riboflavin due to that channels or by means of the channel system is comparable to the technique used nowadays. And the 25% less stiffening effect, we think that this comes from the thing that we still have the epithelium on. This epithelium absorbs UVA irradiation that afterwards misses in the stroma to produce cross-linking. And there's also the fact that the riboflavin that we applied intrastromally, this also diffuses, diffundates into the epithelium, and this also absorbs their UVA radiation that misses afterwards. So, but we can easily just increase the total energy applied to the cornea, so that we probably receive the same effect of stiffening as we used in the Dresden protocol, but without the epithelial removal. So we should get less complications and to make the whole procedure of cross-linking more safer. So then we've seen that the UVA absorption with the intrastromal application is much higher, so we do have a reduction of risk to harm more posterior structures of the eye, such as the lens or the retina, because we know that, we think that the endothelium is not harmed anyway, as the absorption is much higher, but this we also need to prove by other animal experiments first. Here you can see something from the Crosslinking Congress. This is a new technique to show the effect of cross-linking with Brillouin scattering. Here we can see a group of untreated corneas. We see that the effect of stiffening is lower than in the group of treated corneas. These were examined bovine corneas. That's the reason why they are very thick. So also animal experiments. And we can see that crosslinking just increases the stiffness of the anterior stroma. And as we can see that in the first part, or in the most anterior part of the stroma, we do get the highest rate of stiffening, and then a linear decrease until the threshold of the riboflavin. We think that this is proportional to, or this must be proportional to the concentration that is in the cornea of the riboflavin. As we now have the chance, due to the channel system, to vary in which depth of the cornea we want to have what concentration of riboflavin, so in which depth of the cornea we want to produce the corneal crosslinking or the stiffening, we could think that we could produce, due to the channel system, we could produce such a curve that we have a crosslinking effect through the whole anterior 300 micrometers of the stroma or 350 micrometers of the stroma. But first of all, we need to do more investigation on the optimization of this whole procedure, and this will take at least the next half year to a year. So maybe we'll find this approach in about 2 years or 2.5 years in clinic, but this is just, as I told you, just an approach. And then the last thing that I want to show you for an epithelium-on method of corneal crosslinking is iontophoresis. This is just new, brand new. It was first published in 2013. Also, and they are also just doing animal experiments yet. There we apply an electric field on the eye, where we do have, as you've seen here again, the riboflavin molecule. We can see that there's a huge negative charge on the molecule, and therefore we can use an electric field to push the riboflavin into the cornea, into the corneal stroma. And the anode is on the eye. We can see it here, and the anode is here, and the cathode is here. So the current, it's a DC current of 9. It's battery of 9 volts, which then goes through the eye into here, and so we can push the riboflavin into the stroma without the epithelial movement. But this is also still experimental, so maybe you hear something about it in the next 2 or 3 years. But till this goes into clinics, this will also take its time. So can we avoid the abrasion so that we get less complications due to the procedure of corneal crosslinking? Yes, we can do this, but the correct formula and technique is not yet proven, and you should not use transepithelial crosslinking in clinics. So the take-home message is the shorter irradiation time. Yes, we can do this, and we're already doing this in Zurich. The shorter diffusion time, no, because we can't change the diffusion constant. This just takes its time. The epithelium-on method will come. We just don't know when, but this is coming soon. And the better efficiency due to the donut profile, this is already in the clinics and already used. So the question for you is now, why is the epithelium removed before the crosslinking treatment? Is it removed because of the increase that we do have a higher energy delivered to the stroma and produce more crosslinkings? Or is it to achieve a high enough concentration of riboflavin in the stroma? Or is it just to prevent complications? So thank you very much for your attention.